for months before they say that they have a problem. And there's usually sputum with this because the bronchiolitis has lots of mucus. Increased breath rates, they can be increased by 20 breaths a minute, which is really large. The lung hyperinflation, these people will be associated with big barrel chests because they will be hyperinflated. Diminished breath sounds, these breath sounds will have crackling and wheezing. And then the cyanosis, this will be the blue discoloration of their skin because there's less oxygen in the blood. Some risks that you need to look for these patients are unintentional weight loss, diminished appetite, because a lot of people have, less ability to cook for themselves, and it's extra tiring to eat, so they won't. They have the diminished ability to shop for food and prepare their meals, inability to sleep because it's harder to breathe, exhaustion from overworking to try to just breathe, and then the shortness of breath you need to look for. So we'll go into the treatment. There's no cure for this disease, it's just preventing the symptoms and the progression. It's basically to make them have a better lifestyle during the disease. So a lot of people use oxygen therapy, medications, and then if you look in the nutrition therapy, we want to correct for the malnutrition, and we want to prevent muscle wasting. So we want to increase protein for these patients, keep that bone muscle healthy, continually using it, and then it's deteriorating. Maintain a healthy body weight. So people that are on have bronchitis might be on steroid use, might be eating a lot, and extra weight can cause extra pressure on the lungs. And also, the more that you eat, the more excess CO2 is put off. So you don't want someone to put off too much CO2 in their body since they can't eliminate it. You want to do a consumption of small meals. So we all know what it feels like when we eat a big giant meal and our stomach's super full and we just want to lay back and go to sleep. And it pushes all that pressure on the diaphragm, so you just want to go to bed. So we encourage these patients to have small meals so there's no pressure on the lungs, on the diaphragm, so it's easier to breathe through them. And also it takes a long time for them to eat because it's hard to breathe and the movement of breath. So small, frequent meals so that that's eliminated. The fluid intake, there's a lot of mucus production in COPD, so we want to make sure that they have adequate intake to break down that mucus. So we want to make sure that they have that for hydration. And then reduce sodium. We don't want edema to accumulate, especially in the lungs. We don't want edema, so we want them to be on low sodium diets so that there's not extra pressure on the lungs. And then calcium, which I didn't really know why the link between them, but it's because of the steroid use. And the steroids uses in COPD, steroids can increase the calcium loss. So osteoporosis is very common with people with COPD because of the steroids that they use. So we want to make sure that they get adequate calcium intake so they don't have osteoporosis. There's nutrition support for COPD patients. The traditional nutrition formula is high in fat, low in carbs, such as Pulmicare. And the reason for this is because fat uses less oxygen to be digested. Carbohydrates use more oxygen, so they put off more CO2. So you want less CO2 production in the lungs so that you're healthier. This helps patients get off vents quicker so they don't have more CO2 production. But whenever I went onto the nutrition care manual, they stated that the traditional formulas aren't warranted anymore. They said that the high fat content, a lot of these patients have heart problems. They also, there's a lot of GI discomfort with the high fat content of the diet. So they really just want people to don't overfeed the patients on the vent more than these traditional formulas. Overfeeding obviously produces excess CO2 because you have excess food. But there's some new studies out there about the high fats. But the studies I did find, the fat content does decrease the CO2 production, but there's always other problems going on with the patients that isn't really beneficial. The condition presence, it's actually the third leading cause of death, which in the U.S., which I thought other diseases were higher. But it is in the U.S. and it's 13.5 million For bronchiolitis, ages 18, everyone can be affected by bronchiolitis. Ages 18 to 44 is the lowest, and the highest is 65 and older. But with emphysema, 93% of those people are 45 or older. So it is an older population because of the increased stimuli. You have to have that increased stimuli of, say, the smoking long time for that inflammation to produce these symptoms. So you have to be older and have longer use of cigarette smoke to have that. And then some of the coding and reimbursement for COPD. And then my references. I did get a lot of the information from the Nutrition Care Manual, and that's where I found about the formulas. So my patient, Mrs. M, I was at Allegheny General for my rotation, and I found her there. She's a 69-year-old female. So Mrs. M was brought to AGH because she went in for a colonoscopy review, and she developed shortness of breath, and she said that her throat felt swollen. But she had no facial edema, like it was an allergic reaction, and they weren't sure what was going on. So they sent her in for shortness of breath. She has having another colonoscopy because in her last colonoscopy in 2005, she had a 60-pound weight loss from it. So she's scheduled for that at the day after she was admitted. And they wanted to figure out where that's from. Her medical history, I just wanted to point out, she does have type 2 diabetes, and I want to talk about that later. And if you notice, she has the osteoporosis because she has been on steroid uses. So I wanted to show that. But she is 69, so she has all these other diseases. And her colonoscopy in 2002 was actually normal, so there's nothing wrong with it. So we needed to figure out if it was just wasting from her not eating, or if it was truly a GI problem. I didn't get to see her after her colonoscopy to know if it was from her COPD or from a GI problem, but she has been losing weight since then. Some of the medications she's on, I pointed out Breo. Breo is the steroid mixed with the bronchodilator, and then she's on Spiriva. It's also a bronchodilator, and Solumedrol is another anti-inflammatory drug. So she has those steroid uses, she's on the bronchodilators. Bronchodilators relax the muscle airways and increase the airflow to the lungs. Her disease risks that she was experiencing was she had exposure to tobacco smoke. She had a significant history of tobacco smoking. She smoked all the way up till 2 years ago is when she quit. So she's 69, so she smoked for quite a few years. And then age, so COPD affects the older population. So her age and her smoking patterns. Like I said, she had a significant history of smoking, and she denies any alcohol use or illegal drug abuse. Her social economic history, she's retired and lives at home. She has no cognitive impairment noted yet. She's African American, she's Baptist, and she's divorced. For her diet history, I was in the room talking with her, and she reports that she cooks for herself and another gentleman. The other gentleman was actually in the room with her, and he actually butted in on a lot of things for her. Like for lunch, she said, "Oh, I normally eat a sandwich." And he said, "No, you never eat your sandwich, you never finish it. You barely ever make it for yourself anymore." So she's trying to say that she eats more than she does, but she truly doesn't. She said her appetite's been poor for a long time now, and she states that she barely eats as much as she used to. And she normally only eats a meat and a grain at breakfast and dinner. She tries to drink Binge or the Boost when she can afford it. And I could see from just being in the room that she cooks, she does most of the housework. She was talking about how she cares for him. And so she's probably exhausted from cooking and from doing these things. So by the time she sits down and eats, she doesn't have the energy to eat. And then if you also look at her diet, the COPD is making her exhausted, and it's making her tired, and she's not eating correctly. She's just eating what she feels like eating. Her type 2 diabetes is being affected too because she's not eating normal meals. She's not eating properly because she's tired. So you'll see in later slides that this diet's not helping with that disease either. So it's not just affecting the lung problems, it's affecting other diseases she has. So her anthropometrics are, she's 69, she's 5'4". I wanted to show you that her BMI is just a little overweight, but and right now her usual weight is around 150 right now, but she had that 60-pound weight loss. So for her, 150, even though it's overweight, is not normal. Normally it's about 210. So this is weight loss. This is not normal for her. So we need to wonder what's happening and why she's depleting. And then we look at some of the labs. Like I said, her glucose. She's on steroids. She has type 2 diabetes. She's not eating well. So this could be a number of things. The steroids can increase her glucose levels. She's not eating well, and not eating properly, that can increase it. And she's under a lot of stress from the exertion of breathing. And then normally we measure like the arterial blood gases for COPD, and usually CO2 is high because you can't expel the CO2. And for her, it's actually on the lower end, and it's normal. So I was wondering how she was doing with that. She must be doing well with her drugs, and if it's on the lower end, that could be because of like hyperventilation. Her clinical conditions, she came in because of shortness of breath during her colonoscopy. She was admitted for COPD, acute hypoxia, and reduced vocalization. She did complain about her swollen throat, and she was really hard to interview because it was hard for her to talk. So the gentleman did butt in and talk over her a lot. It's kind of funny. The hypoxia is the sudden rapid depletion of available oxygen for the tissues. So they wanted to check these out to see why she had the swelling in her throat. So they looked for they checked the CT to rule out pulmonary embolism, and they also did neck imaging to rule out laryngeal anomalies to make sure that she was doing okay. And then for her, I went with the PES statement of inadequate oral and food and beverage intake related to shortness of breath and COPD, as evidenced by poor intake of less than 50% of meals and skipping meals. And this is self-reported because the day she got admitted to the hospital, she was on clear liquids for a colonoscopy. So I didn't have a record of what she ate at the hospital while she was still on clear liquids. I'm not sure if they actually went through the colonoscopy because she was discharged only 2 days later. So I wanted to ask her how she was doing, but she did state that she's eating a lot less than she normally does. And then my second one really is not necessarily due to COPD, but she did have altered nutrition-related lab values related to steroid use and type 2 diabetes, as evidenced by glucose greater than 200 for extended number of days. She said that she runs high now, and she does have a steroid use and a stress. So for her, at my hospital, we use the Mifflin St. George if the patient's not on the vent or BiPAP. We normally use the Penn Stage if not. So Mifflin St. George told her that she needs 1,400 to 1,500 calories a day. For protein, for depletion, we did 1.2 to 1.5 for COPD patients because of the extra exertion. So she needed 72 to 90 grams a day. And her fluid requirement, I normally would have done 1 kcal per ml, but it's a little bit low, so I went with 25 mLs per kg so that she gets a little bit more hydration to break up that mucus. For her nutrition and prescription, I wanted to advance her diet to a consistent carb diet at our hospital with a 2 gram sodium restriction. She did have hypertension as well, so we wanted to keep the edema off and make sure that she got a good, consistent carb diet. I wanted to initiate the oral supplement Glucerna. She said that she likes oral supplements. She just tries to have them whenever she can afford them. And I encouraged her while she was there, if she was put on a diet, to pull the supplement off the tray and keep it and drink it after she was done eating. Eat the food first, wait a little while, and then drink it so she doesn't fill up on the supplement first, because we wanted the small frequent meals so that she doesn't get overexerted for eating. And then I wanted her to consume 75% of the oral supplements to maintain lean body mass. And then I also wanted to encourage the staff to order the consistent carb diet because of her blood glucose levels, and we wanted to keep those in check. For monitoring, we wanted to monitor the patient's PO intake and advancement to the diet, see how she was doing with the advancement of the diet. Monitor weekly weight changes because she has been continually losing weight. We wanted to monitor lab values, and then I didn't quite get to evaluate everything because she was only in the hospital for 3 days. So I only followed up with her twice, and by the third time I went around, she was already being discharged. So I wasn't able to follow up with everything, how she was doing. And that was my patient. Does anyone else have any questions? Yes.
You know which came first, the COPD or the diabetes?
She did not answer that. I feel
What
like,
would you guess?
well, I feel like she said that she just recently got diagnosed with COPD because she's like, oh, it's just a smoker's cough. But, so I think the diagnosis might have been not coherent to when she actually had COPD because she just said she had a smoker's cough for a while and then she got diagnosed with it. So, for her, she was 210 pounds for a while. But I'm thinking because she was on prolonged steroids that maybe the diabetes came afterwards.
Excellent. Almost always a COPDers when you have diabetes because of the
Just the steroid use.
Solmedrol and all, yeah.
Yeah.
Good.
She had like talked about her diabetes like she had it and she doesn't really, but I'm not
She
sure.
could have, but she maybe didn't have the COPD diagnosis.
Diagnosis, right. I mean, I think the COPD diagnosis technically came after, but she just covered up with I had a smoker's cough. That's why I quit. So, any other questions? Thank you guys.
I just had something quick to ask you. You said that you had a colonoscopy and then she lost 50 pounds?
Yeah, she had a colonoscopy.